About the cards.
Okay. Oh, before I go on, let me just mention this because I just got an email yesterday about this. The way that OpenStax works, the books being online can be modified and updated in a much quicker response than a printed book can be. If you come across problems, by the way, misspelling or something that doesn't seem to work, I think if you go to this Ask Us tab over here, it'll give you a place to like type in sort of an email message and let them know when there's a problem. If it's an error in the book, let me know also. And if it's not something that another student has pointed out to me, then I'll give you an extra credit point for that. But as people submit errors and problems that they find in the book like that, they go through and they make updates on the book every so often. Minor updates can happen pretty easily. Major updates, I think they do once a year. And when they do that, there'll be a new link to the book. So you'll see that yellow bar that comes up that says a newer version is available. It's a little bit of a pain for me because now I really need to go through and fix the links that I've given you. Like this. And I've got to go through and do that for all of the links and all of my courses at some point. And I usually do it like when I notice it here, and you get to watch me do that little thing. But if you ever click on a link to the reading, and there's a yellow bar that says that there's a newer version, please click on that and go to it. The title here, it says Anatomy and Physiology with Concept Coach. It's a special version of the book that has the Concept Coach part in it, and they're updating that also. What was I going to say? Some of you might have noticed, I was asked about it yesterday. It actually came up, I think, Sunday. A couple of students in another class pointed out. The blood vessels chapter, the link that took you to the reading there was actually wrong. I fixed it since, but it used to say reading for the week, unit 3, chapter 4, unit 4, chapter 3. I don't remember what it was. And that's just because when I was going through and updating all the links, adding in the Concept Coach stuff, I forgot to do it for the blood vessels chapter. And so people that clicked on that link got there and there was no Concept Coach there. And that was completely my fault. I have since corrected that, but if it comes up again, if you notice in the Blackboard site, if it says reading for the week and it doesn't just say chapter number or whatever, it says unit and chapter number, then that's probably something that I failed to update. I think I have them all, but sometimes stuff falls through the cracks. But if that ever does happen, what you can do is go back to a folder on Blackboard that went to a version of the book with Concept Coach in it correctly, and just move ahead to the reading. So when I first got the couple of notices that there was a problem with the Concept Coach thing, I wrote back to those students that contacted me over the weekend, and said, go back to the heart chapter and then click the next button to go into the vessels chapter and see if it's there or not. And it was, and that sort of proved that it was my mistake. I put the wrong link in there, but you can do that to get to the material you need to, if there's a mistake. But just being an online book that they can modify a little bit here and there, pay attention to if it says that there's a newer version. And we're actually in a special version of the book, not the regular version that has the Concept Coach stuff in that. And so if you have a problem with Concept Coach in one chapter, just go back to another chapter link on Blackboard and see if you still see that problem with Concept Coach coming from a different way, and that might clear things up quickly. Question?
Which concept coach are we supposed to have started by today?
We're still doing the heart stuff, so I doubt that we'll necessarily start the blood vessels until Tuesday. So I don't remember when I put the due date for the heart stuff in the system. Oh, wait. No, we might start vessels on Thursday. We'll see where we get to at the end of today's class, and I'll answer that question more specifically. But for today, there wasn't any Concept Coach stuff to do because you should have already done the heart stuff before Thursday of last week. So, okay. Other questions? Okay, so we were looking at the cycle, this circular representation of it here, right? Did we get to looking at the linear version of it, laid out like this? We hadn't gotten to that yet? Okay. Oh. Okay, so just to recap briefly, and actually I think one other thing I need to say about this. This is a cardiac cycle. This is what happens over the course of a single heartbeat. Systole refers to contraction, diastole means relaxation. So within a heartbeat, we can consider the two types of chambers, the atria and the ventricles. They contract and relax separately. So we start the cardiac cycle at this point. Actually, the start box should be up here, which corresponds to the beginning of the EKG. So we start with the atria contracting, both right and left atria contracting, pushing what blood remains in them down into the ventricles. That lasts for about 100 milliseconds. And when that ends, the atria start to go into relaxation and the ventricles start to contract. And ventricular systole lasts for 250 to 300 milliseconds. I think 270 is usually the number I read about when the ventricles contract. And then that ends, and the ventricles are in diastole for the remainder of the heartbeat. The heartbeat ends here, the next one starts. The ventricles stay in diastole while the atria and systole in the next heartbeat. They just sort of go back and forth between those two. So we could say that there's sort of three major parts of the heartbeat: atrial systole, ventricular systole, and then when everything's in diastole. Now the atria are in diastole when the ventricles are in systole, and the ventricles are in diastole when the atria are in systole. But from this point on through the rest of the heartbeat, both the atria and the ventricles are in diastole collectively. Diastole means relaxation, but I like to emphasize that everything's relaxed for that back half of the heartbeat. Call that the relaxation period. Just to stay away from diastole and naming that, and just say everything's relaxed. That's one way to think of it, the sort of three major things happening. But also we can look at it as having 5 parts, which is what these 5 pictures are showing us. I didn't talk about this last week. 5 parts. Okay. So the first thing that happens is atrial systole, and there's a picture for that specifically. And that's what happens in the first 100 milliseconds. And then during ventricular systole, there's 2 events that happen. The first thing is isovolumetric contraction. In the book here, they have isovolumic and isovolumetric, 2 different words that essentially mean the same thing as far as we're concerned, which is the volume doesn't change. So iso as a prefix in a word like that means same. So isovolumetric means the volume doesn't change. And we're in ventricular systole, so that's why it's called contraction. When atrial systole ends and ventricular systole starts, the AV valves close. Okay? And we'll talk about what causes valves to open and close in a little while, but that's when it happens. So the AV valves are closed. The semilunar valves are closed because they've been closed all along. So all 4 valves are closed. No new blood can get into the ventricle and no blood can leave the ventricle at this point. It's sort of like in this room, there's 3 doors, which are all closed. Nobody can get in and out unless we open a door. So that's what isovolumetric is talking about. But the ventricular walls are starting to contract, and so isovolumetric contraction. You can't, and I've already actually this one. Okay. I can't squeeze this bottle and push the contents out, but the pressure in here is increasing because I'm squeezing this bottle. That's what's happening in the ventricles. The pressure will get high enough eventually to push open the semilunar valves. And so we go from isovolumetric contraction to ventricular ejection, which is when the ventricles are contracting, they're pumping the blood out into their respective arteries. Now, in the drawing, because all of the hearts are drawn to the same size, which makes sense, it also suggests that these 2 things are kind of equal in size within ventricular systole. That's in fact not true. Isovolumetric contraction, as far as the time frame is concerned, probably only lasts for the first little fraction of systole, and most of ventricular systole is ventricular ejection. And we'll see that in a picture a little bit later on. So there's actually 2 things going on during ventricular systole, which has to do with when valves are closing and opening. Everything's closed at the beginning of ventricular systole, and the semilunar valves don't open up for a brief while because pressure has to build up to cause those valves to open. At the end of ventricular systole, blood's been ejected out of the ventricles into the arteries, and so the volume's at its lowest at this point. The pressure in the arteries will now be higher than in the ventricles, and that'll close the semilunar valves. So we go into ventricular diastole as the isovolumetric relaxation period. Okay, so just like isovolumetric contraction, the difference is just what the muscle's doing. Here the muscle's contracting, here the muscle's relaxing. But now that the semilunar valves have closed and the AV valves are still closed from before, all of the valves are closed, so no blood can get in and no blood can get out. It's isovolumetric again. But everything's relaxing. Again, that takes very little time. So it's sort of just a sliver at the beginning of ventricular systole that occurs. And once the pressures change, the AV valves open, and blood in the atria can move into the ventricles. This is called ventricular filling. This is passive. Just the valves are open, blood in the atria can then just go down into the ventricles. At the end of the heartbeat, here where we start into atrial systole, this is where the atria contract and push the blood down to the ventricles, which the blood's been moving that direction all along. Atrial systole just pushes the last little blood out that it can. So up until atrial systole, ventricular filling is passive. And then after that, when the atria contract, that's an active form of pushing the blood, pumping the blood from the atria to the ventricles. So we're really filling the ventricles from when the AV valves open, probably right about here, time-wise, all the way through here. It's just at the end of one heartbeat and the beginning of the next, when we switch from the relaxation period where everything's relaxed to atrial systole, suddenly we add in the contraction of the atrial wall to push extra blood into the ventricle. So again, 5 events in the cardiac cycle, atrial systole, and then ventricular systole has 2 parts, which is isovolumetric contraction, which is very brief, and ventricular ejection, which is the majority of the time. And the relaxation period has 2 parts, which is isovolumetric relaxation of the ventricles and ventricular filling, which is the majority of the remainder of the time. So those 5 pictures basically show the 5 different things that are happening during the single cardiac cycle, single heartbeat. Another way to look at the heartbeat, instead of the pictures here and doing it in a round, we can also lay this out in more of a linear fashion. So this gray bar at the bottom is showing you this is one cardiac cycle. It starts with atrial systole, which again just reinforces that they put the start thing in the wrong place in that previous picture. And then when the atria are done contracting, they go into their diastole, the ventricles start to contract, and that lasts for this long, and then the ventricles go into diastole, and the remainder of the cardiac cycle, the 2, all 4 chambers are all relaxed. We call that the relaxation period. Here they've tied it to the progression of the EKG trace. So the P wave starts actually a little bit before atrial systole. At the peak of the P wave, that's when all of the atrial walls depolarized, and so that's going to start contraction, which will last into the QRS complex. When the QRS complex comes to a peak, that's when the ventricles are completely depolarized, and ventricular systole lasts through the T wave, which is when the ventricles are repolarized and they'll be relaxed. So we can see how the EKG trace corresponds to the events of one heartbeat, the atrial systole, the ventricular systole, and when everything's in diastole. Okay. Now, in a lot of books that are presenting this, they'll actually put this figure and the next figure I'm going to show you together, just to show you that everything lines up. So just imagine these events and they correspond to this picture, which is showing specifically the pressures that we can measure in the heart during the cardiac cycle. So if we lined all of that up, atrial systole would start here and end about here, and then ventricular systole would start here and end here, and then we'd have the relaxation period when everything's in diastole from here until we start the next one. Just sort of imagine how that's lined up. And I'll reinforce that a little bit as I talk about it. Now, pressure is a very important concept to think about because it's what's making the blood move. In fluid dynamics, if you will, which I'm using that term because it would apply to gas and liquid. Both of them are fluid states of matter. Fluid will always move from high pressure to low pressure. The reason I'm setting it up that way is because right now we're talking about blood, which is liquid, and that's true, that blood will move from high pressure to low pressure, and that's really what regulates or determines the movement of blood through the cardiovascular system. We will visit that same idea again when we get to the respiratory system, because the movement of gas is dependent on the same thing. Gas will move from high pressure to lower pressure. The pressure that we use, the units that we use, is millimeters of mercury. It's sort of an old-fashioned unit. It's not going to probably be replaced anytime soon, although there technically is a unit that's equivalent to it, but isn't so old-fashioned. It comes from devices that measured pressure, like old blood pressure cuff systems or anything like that, where a column, a glass tube, had a column of mercury in it, and mercury's affected by the pressure of the container it's in to expand or contract within that column. And how many millimeters of mercury there is in that column tells you the pressure in there. That aspect of fluid dynamics, and specifically what a liquid metal like mercury can do, is a little bit beyond my expertise. So that's my best explanation of it. But it's the mmHg is millimeters of mercury, and it's based on a column, a glass tube filled with mercury, and how many millimeters that mercury moved up the column. There is another unit that essentially is the same thing, but it's not called millimeters of mercury. It's called something else, but it's an equivalent unit that gets used sometimes, especially in respiratory therapy. But when we're talking about blood pressure, we usually stick with the millimeters of mercury. So we have three lines here: a green one, a yellowish one, and a red one. The green line represents the pressure in the left ventricle. The yellow line represents the pressure in the left atrium, and the red line represents the pressure in the aorta. Now, obviously, I mentioned specifically the left atrium and ventricle, and I'm not mentioning the right. And that's because the numbers we're looking at here only apply to the left side of the heart. On the right side, the same things are happening, it's just that the pressures are much different. Okay, remember the ventricular wall on the right versus the left side are different, so those muscles, when they contract, generate different amounts of force. The pressure on the right side is less than the pressure on the left side. And that's mostly because of where the two sides of the heart are pumping the blood. Pumping blood into the lungs doesn't require a whole lot of force, but pumping blood around the entire body does. So the pressure on the left side is much higher than the pressure on the right side. So again, we're talking about the left side, and that's what these numbers apply to. We won't really talk about the numbers on the right side because it's just not as important in the system. The reason why we're paying attention to the left side is this is what establishes systemic blood flow. This is what pushes the blood throughout the whole body. So we're most concerned with that. So as we look at this graph at any particular time, when one line is above another line, we can assume that blood is moving from one location to the other. Now, that's not exactly always true because the anatomy of the system determines where things flow. Blood will only flow through valves in one direction. So we wouldn't really say that because the aortic pressure is higher than the atrial pressure, that blood's going to flow from the aorta into the left atrium. Technically, that's kind of true, except that really the aortic pressure is what establishes blood moving through your whole body and getting back to the right atrium. And that's because of the anatomy. That's where the blood has to go from the aorta. It can't go back into the left side of the heart. So at the beginning here, the difference between the yellow and green lines is what's important. The pressure in the left atrium is slightly higher than the pressure in the right atrium, that means left ventricle. And so blood moves from the atrium into the ventricle. When these two lines start to go up in this curve, that's when we start the heartbeat. That's atrial contraction. So the two rather flat lines we see at the beginning of the curve are really representing the blood from the previous heartbeat. This is ventricular filling, passive filling that comes during the relaxation period. Atrial contraction increases pressure in the atria, which is going to help push the blood out of the atrium. As that blood is pushed out of the atrium into the ventricle, it's also going to increase the pressure in the ventricle. So these two lines both go up, curve up a little bit, and the pressure falls off a little bit as the contractions finish. But the green line and the yellow line overlap so that the pressures in the two become equal, and the green line eventually gets higher than the yellow line, meaning ventricular pressure is higher than atrial pressure. Now, the AV valves are like funnels. The blood's running from the atrium into the ventricle, and the pressure is sort of pushing the valve open. When the pressure on the other side of the valve in the ventricle gets higher, it'll push back against the valve, closing it. And that's what happens right here. The AV valve closes. We're on the left side of the heart. That's specifically the mitral valve closes. Because of that change in pressure. Higher pressure on the bottom side of the valve is going to push it closed. So the AV valve's closed, and the semilunar valves are closed from the previous cardiac cycle. So all of the valves are closed. This is where we start ventricular systole, specifically isovolumetric contraction, because this is when the ventricles will contract, and all of the valves being closed means that the blood volume doesn't change. The green line rapidly goes up because that ventricular wall is contracting, and like I was showing with the Gatorade bottle there, trying to sort of squeeze it. Now, I made sure that the lid was on the Gatorade bottle while I was squeezing it so that I wouldn't pop the lid off. But when the ventricular pressure gets high enough, when it gets above aortic pressure, that actually does push the semilunar valve open, and we start to eject blood from the ventricle into the aorta. And the pressure goes up in both the aorta and the ventricle. Now, this picture and most pictures from similar textbooks usually get this little thing wrong. And the reason is just because the person drawing the picture isn't technically a scientist. So the green line should stay above the red line the whole time until we get over here. The red line here is shifted over, I don't know, a millimeter or two, whatever. And so they should be much closer together, and the red line should stay below the green line until we get to this point right here. So it's just a little quirk in how it was drawn. The graphic artist wasn't paying close attention to exactly what the red line should look like. I did a search actually. Just an image search for ventricular pressure, and I came across, oh, this might be good. Nope. Okay, so this is just from a different source, and they do the same thing. The dotted line here is the aortic pressure, and that curve is kind of not following the ventricular curve. This one comes from a book, they got it right. The aortic pressure is a blue line, which is below that green. Yeah. This green line, which is the ventricular pressure, until we get to that point. Okay. That's when we want to see the aortic pressure and the ventricular pressure overlap in the drawing, because that's where it's actually happening. Because just like down here where the green and yellow lines overlap, the green and red line should overlap, and that causes the semilunar valve to close. Okay, so the semilunar valve is open as ventricular pressure is pushing out. Once the aortic pressure gets higher than the ventricular pressure, that would close the semilunar valve. If this was accurate, where the green and the red actually crosses over, that's where the semilunar valve would close, but that's not correct. Okay. So the line should be crossing over here where the arrow is pointing at semilunar valve closes. So the semilunar valve's closed. The AV valves are still closed from previously. And now we're into another isovolumetric situation. All of the valves are closed. No blood's getting in, no blood's getting out. But at this point, the ventricles have stopped contracting. So we're in the isovolumetric relaxation, and the pressure goes down very, very quickly until the green line crosses the yellow line again. And as soon as the yellow line's above the green line, the AV valves can push open again. And the yellow line stays above the green line all along, and that means that the pressure in the atria is higher than the ventricles, and blood fills the ventricles. So from when the AV valve opens until we start to see contraction of the atria in the next heartbeat, that's ventricular filling. The yellow and green lines are further apart at the beginning of this picture than they are over here. And again, that's just a artist's rendition mistake. So really the distance between the two lines should be the same at the end of last heartbeat and at the end of this heartbeat. They just didn't draw it quite right. But at least they are correctly yellow above green there. Okay. So that's what's happening over the course of a heartbeat as far as the pressure. Okay. Blood moves from the atrium to the ventricles until the AV valves close. Pressure builds up until the semilunar valves open, and then blood moves from the ventricle into the aorta until the semilunar valves close. Pressure drops in the ventricles until the AV valves open, and then blood moves from the atria into the ventricles again. At both points where the lines cross over and valves close, so where the AV valves close and the semilunar valves close, that's followed by a bump in the pressure of the chamber, if you will, on the closing side of the valve. That makes sense. So when the AV valves close, there's a little bump in pressure in the atrium. And when the semilunar valves close, there's a little bump in pressure in the aorta. This little notch here, this little notch here. Those line up with these sort of spiky looking things at the bottom, which is heart sounds. If you're listening to the heartbeat, you hear a couple of sounds, which are actually when the valves are closing. The first sound is sometimes referred to as lub, and the second as dub. So the heartbeat goes lub dub, lub dub, lub dub. And what you're hearing is actually the sort of kickback of pressure in the atria or the aorta with the closing of those valves. Actually, if you think about the whole heart, it's just the kickback in the atria after the AV valves close, the kickback in the arteries after the semilunar valves close. You can listen to specific valves depending on where you put the stethoscope around the heart. And there's a picture in the book about that. But overall, just the sound of the heartbeat is about the valves closing and the sort of back pressure behind the closing valve. I can't do this with one of these doors because these four bolts up here are where things connect to the outside of the door, so I can't slam it. But if I could slam it really hard, when it closed, there'd be a little gust of air, just the door pushing air into the room. And that's what the valves are doing. They sort of push the blood back into the atria for the AV valves or the artery for the semilunar valves. Just a little bit of back pressure from when the valve closes. And that's what establishes the heart sounds. Now there's a third heart sound there. I'm not quite sure what technically causes that. It's the size that's drawn there is much smaller than the first and second, and you don't normally hear the third heart sound unless you're listening really close or you're really good at listening to those things. And I'm not quite sure what technically causes it, but the first and second are definitely tied to when the valves close. So this is, again, tied into the events of the cardiac cycle. Let me go back to this. Atrial systole is when that curve represents the atrial contraction. And then ventricular systole is when the ventricles go way up and then come down on the other side. So the cardiac cycle, as it's laid out in a straight line rather than the circle that we first looked at, like this, the straight line here corresponds to the events here. This is atrial systole, this is ventricular systole, and then this is when everything's in diastole, everything's relaxed. Any questions about what we've seen here, laying out the sacral heartbeat? No? So in the book, I showed you this and this figure here. The book includes also a picture of where you can listen to the specific valves, but we're not going to necessarily do that, but it addresses those sorts of things. Something that's missing from this section of the book, there just isn't a picture of it. Let me use one of these pictures here. Okay. So this is a picture from a different book, but kind of shows all the same things happening. What's different, what's not included in our book, is this graph right here. The scale up to the side, the 50, 90, and 130, that's volume. So that's in milliliters of blood. And what we find is over the course of the heartbeat, the volume of blood in the ventricle changes. The solid line we see first here, this is when the AV valve closes. And then the dotted line next to it is when the semilunar valve opens. And then the next solid line is when the semilunar valves close, and the next dotted line is when the AV valves open. Okay. So the volume of blood in the ventricle coming from the previous heartbeat is here, and it increases sort of to its maximum when the atrium contracts and pushes the last of the blood in. From this point to when the valves open, the volume is pretty much constant. That's the isovolumetric contraction time. And then once the ventricles start contracting, once the semilunar valves are open, when the ventricles are contracting, then we're ejecting blood and the volume goes way down until we get to this point when the aortic valve on the left side finally closes. And the volume stays constant until the semilunar, the AV valves open again when ventricular pressure drops way down. So this is isovolumetric also. I want to label a couple things here. Excuse me. So let me just move the. All right. I hope I've run out of black pens myself, so I hope this red one that I have here is starting when the ventricles, when the atria are contracting, the ventricles are relaxed. And at this point where we switch between atrial contraction and ventricular contraction, we can refer to the end diastolic volume. So this is the end of ventricular diastole, and that's the volume that we record there, which according to this is 130 milliliters. The ventricles are contracting and ejecting all that blood during the ventricular ejection part of the heartbeat until we get to this point here, which is end systolic volume. So it's the end of ventricular systole and the volume that we see there, which is 50 milliliters, according to this figure. Okay. We don't completely get all of the blood out of the ventricle. Okay. We get down to a low volume, but there's still some blood left there. You can't completely squeeze all of the blood out of the ventricle. Just if you did that, there'd be a vacuum in the ventricle, and that just wouldn't be feasible. It's like I compared the ventricles contracting from the apex up towards the semilunar valves, I think in lab, to squeezing a toothpaste tube. You also can't get all of the toothpaste out of the toothpaste tube. You can squeeze as much as you possibly can, get most of it out, but there's still going to be some left. Unless you tear it open and scrape out every last little drab of toothpaste. There's always going to be some left in the tube, just like there's always going to be some blood left in the heart, okay, with each heartbeat. The difference between these two, the difference between end diastolic volume and end systolic volume, we call stroke volume, or SV. So stroke volume is just the difference between these. So what is 130 minus 50? 80. So the stroke volume here is just 80. It's just a simple it's just a simple difference between the two. In the book, they don't have any representation of that with a graph like that. But in the next section of the book, we're going to be dealing with what's called cardiac output. And cardiac output is essentially is the job that the heart does. Okay? It's a measure of how well the heart's working, you could say. It's defined mathematically here as the heart rate times the stroke volume. What is heart rate? Yeah, just how many times the heart beats per minute. And what's stroke volume?
ADV minus ESV.
So if we define heart rate as the number of beats per minute, how would you define stroke volume?
Amount of blood
The amount of blood what?
being pumped
When?
in each contraction.
A contraction could also be called a heartbeat. Yes. So cardiac output is heart rate times stroke volume. Heart rate is beats per minute. Stroke volume is, we're measuring it in milliliters per heartbeat. Okay. And so we're multiplying these two things together. Now I put milliliters over beat as I'm actually, for the sake of recording this, let me do it this way. Oh, I didn't mean to do that exactly, but okay. So that basically means it's beats per minute times milliliters per beat. I could change BPM to beats per minute just as easily, which means that when we calculate, that's not how you spell beats. beats per minute. When you calculate cardiac output, in multiplying these together, the beats in the numerator for heart rate and beat in the denominator for stroke volume cancel out, which means the answer is going to be milliliters per minute. Okay. What's a normal resting heart rate? Heart rate. 72, 75 beats per minute is sort of the normal resting heart rate. Okay. And how many milliliters was the stroke volume we just calculated? 80. And what does that equal? Deanna's doing the math for us.
6,000.
Really?
75 times 80.
All right, we'll go with that. I thought it was 5,000 something, but so that's 6,000 milliliters per minute. Okay. I really thought it was 5 something. Not that I don't trust you, but okay, that's what it is. Those weren't the numbers I usually use. I think it's because a previous book, when it's defining stroke volume, the number that we get from what they give us was 70 milliliters per beat. So that would give me it's actually 5,250 milliliters per minute. But yes, 75 times 80 is in fact 6,000 mils per minute. So 6 liters of blood is pumped by the heart every minute. That's what cardiac output is. That's actually what we call resting cardiac output. So here they introduce cardiac output and the term resting cardiac output, which means how much blood your heart's beating per minute at rest. So that's why we're working with the resting heart rate, and that 80 mils per beat, the number we got from that other figure I was showing you, but that would be around the normal stroke volume for a heart at rest. Okay. The amount of blood in a person's body is close to 6 liters. Okay, the range is usually 4 to 6 liters, depends on the size of a person's body. That's mostly just coincidental. Okay, it's not necessarily that your cardiac output at rest is pushing all of your blood around your body over the course of a minute, but that's essentially what it's doing. That's one way you can think about it. When we need our heart to do more work, then we want to increase cardiac output. We want to send more blood around our body every minute. Okay? And we can do that by altering heart rate or stroke volume. Okay? So if your heart rate goes up, then your cardiac output will go up. If you can pump more blood per heartbeat, then your cardiac output is going to go up. We'll talk about the stroke volume in a little bit more detail in a second, but you're probably already kind of familiar with heart rate stuff. What causes your heart rate to increase?
Hormones.
Hormones can do it. What else can do it?
Sympathetic system.
Right, sympathetic division of the autonomic nervous system. I'm surprised you went with hormones because that's kind of the minor part of what we talk about in class, but that's true also. We spend a little bit more time in this class thinking about the autonomic system altering heart rate. Okay, so that's what actually does it, hormones or sympathetic system. When is your heart rate going to increase?
When you're sick.
When you're sick? I suppose so. That's kind of minor to what I'm getting at. When is it more likely going to increase?
When you have high blood pressure.
No, hopefully it lowers when you have high blood pressure.
Exercise.
When you're exercising, okay. Or when there's a lion on the savannah that's scaring you, something like that, okay. Your basic sympathetic fight or flight type responses. But exercise is probably the most common situation for people in the modern world. And why would increasing your cardiac output be a good idea when you're exercising? For what? Yeah. You need to get more oxygen to the muscles that are doing that exercise. So you want to increase cardiac output. There's a maximal level of cardiac output, which is just called maximal or maximum cardiac output. How cardiovascularly fit somebody is would be represented basically in how much their cardiac output can increase from rest to maximal. For your average person, maximal cardiac output is probably about 3 to 4 times. So if at rest your average person can pump 5 or 6 liters of blood every minute, you would expect that to go up to 15 to 20 some odd liters of blood per minute. Okay. Somebody who's in really good shape, a well-trained athlete, can increase their cardiac output a lot more than that. The numbers I'm about to mention come from a book. I haven't looked elsewhere for verification of this, but a book that we used to use specifically made this point that athlete in good cardiovascular fitness can increase their cardiac output about 7 times. Okay. So your average person 3 to 4 times above rest. Somebody in really good shape can increase theirs a lot more than that. So that'd be almost 4.5 liters per minute, almost 45 liters per minute being pumped around the body if it's 7 times this. So the definition is basically heart rate times stroke volume. There are other ways to define it mathematically that are relevant in other places, which will come up later on. But thinking about cardiac function, this is the way we usually define it mathematically. So we have heart rate, and then stroke volume, which I just explained to you, is the end diastolic volume when the ventricle's as full as it's going to get, minus end systolic volume, which is the ventricle as empty as it's going to get. That gives us the stroke volume. So when I asked, and Ali mentioned, answered, that the autonomic system can affect heart rate and hormones can affect heart rate. Those are the main ways that our body regulates it. How fit you are can play a role in your heart rate. I just mentioned cardiac output being better in people that are more physically fit. For heart rate, it might seem kind of counterintuitive, but somebody who's in that good of shape, their resting heart rate is usually going to be lower. So a good resting heart rate for a very fit person or professional athlete is going to be like 60 beats per minute. Okay? Why would having a low heart rate actually help improve maximal cardiac output?
Your heart isn't working as fast.
Well, that's what we've established. Why does that help cardiac output?
Doesn't overwork it.
Again, you're sort of defining what the resting condition is. I'm asking how a low heart rate at rest is going to help make it easier for cardiac output to increase.
Doesn't put stress in the heart.
Again, that's rest. Heart's in a better position to rest, but
Is
The
it
one
because with each beat you just push out more blood?
Um,
Like the milliliters is greater?
That technically is true, but again, that's at rest. If you have a low resting heart rate, you're gonna have a slightly higher resting stroke volume. But how does that help an athlete get a greater maximal cardiac output than your average person?
So your stroke volume lower?
Actually, their stroke volume at rest will probably be a little higher, but it's a math thing. Okay? If you have a lower number here, that means that you have a better range to increase. Okay? Maximal heart rate is pretty much fixed for people. There's just so much you can increase your heart rate. So if you start with a lower resting heart rate, then you can multiply, you have more of a range to multiply heart rate in there. That's kind of a weird way of saying it, but if somebody's heart rate is 60 beats per minute and then whatever stroke volume would be to give them a resting cardiac output of 6 liters, then we can increase heart rate more than the average person. Instead of from 75 up to the maximal heart rate, from 60 up, you're just gonna get better mathematical results out of it. But to keep resting heart rate normal, the fitness levels which affect heart rate are also going to have an effect on stroke volume, which is here. And actually, to keep things in balance, if you have a lower resting heart rate, you're going to have a greater resting stroke volume. That's the image. Back over here to heart rate. I didn't get to talk about age, but I just mentioned the concept of maximal heart rate, which is kind of fixed. The rule of thumb for figuring out your resting heart rate is 220 beats per minute minus your age, which would suggest that a newborn's maximal heart rate is 220 beats per minute, a 20-year-old's is 200 beats per minute, a 40-year-old's is 180 beats per minute, and an 80-year-old is 140 beats per minute, et cetera, et cetera. That doesn't actually mean that on your birthday suddenly your heart beats 1 beat slower per minute. That's just a rule of thumb for calculating your maximal heart rate. And it's pretty fixed for people. That's pretty much regardless of fitness level, but age does play a role in that. Okay? So those are all things that can have an effect on heart rate, which is to say as people get older, their cardiac output drops too. There are several things that can affect stroke volume. We're actually going to look at 3 of them in some detail, which is contractility, preload, and afterload. Actually, we're going to look at it in the order of preload, contractility, and then afterload. But let me just deal with some of these other things real quick. Heart size would play a difference. A smaller heart is just necessarily going to have a smaller stroke volume. A larger heart will have a greater stroke volume. There are conditions where the heart muscle stretches out, and so that can, certain cardiac conditions can do that, can have an effect on stroke volume. I've already kind of mentioned fitness levels. Gender can have an effect, which is tied somewhat to hormones, just there's a different complement of hormones. And also tied a little bit to size. There's a slight difference in gender, in sort of sexual dimorphism. Generally speaking, men are bigger body size than women, although the ranges overlap quite a bit. So there's, we can talk about sort of a neutral average for all of human population. Duration of contraction, the other thing that isn't one of the ones I'm going to talk about here, actually kind of fits in with the preload stuff that I'll get to in a second. So. That's right. There's not pictures of this. So preload is a characteristic of pretty much any muscle, or I should say specifically cardiac or skeletal muscle. Okay. So what preload is for a muscle is just a matter of stretching a muscle out before it contracts. So you learned about skeletal muscle in AP1, and most of what you learned applies to cardiac muscle too. The main thing is in contraction you have thin and thick filaments that overlap, and because of the ATP hydrolysis of the myosin head, it will actively move the thin filaments across the thick filaments in the sarcomere. Everybody remember that? Of course. Yeah. If you stretch the muscle out, you'll basically be pulling the thin filaments back from the center of the sarcomere, making the distance that the thin filaments can move across the thick filaments greater. So by stretching out the sarcomere, stretching out the whole muscle, you can increase the amount the muscle can contract. Up to a point. If you stretch the muscle out so much that the thin filaments are no longer overlapping the thick filaments, then you're not going to get contraction at all. But if you can stretch it out a little bit more, then you'll get contraction. Now we're talking about cardiac muscle because we're in the heart chapter, but that concept applies to, where did it go? I had a thing that I usually use for this, but I don't know why. It applies to skeletal muscle also. Okay. So if you think about the biceps brachii contracting, and I'm going to throw this eraser. Okay. So if I just contract the biceps brachii, wait, not triceps brachii, sorry. I'm throwing it. Okay. But if I can stretch the muscles out, I can get more contraction out of them. That's basically winding up for a throw. So instead of just throwing like that, if I stretch it, the muscle out a little bit, I can get more power out of the throw. Now, the thing I was looking for is actually my little rubber doorstop. When I'm sad that I can't find it. But it's a more impressive thing to throw across the room. So all I had that I was willing to throw across the room was my dry eraser. I wasn't going to throw my tape dispenser or something like that. I'd probably hit somebody with it if I did. But that's preload. Just stretching the muscle out a little bit, it just maximizes the amount of contraction the sarcomere is capable of. Then contractility, actually let me get back to, since I don't have a visual for this from the book. Let me write these definitions down. Okay, so preload essentially is stretching the muscle or the sarcomere out before contraction increases the amount of contraction possible. Then contractility might sound kind of similar. Okay, I just said that preload will increase the amount of contraction. Contractility is an increase in the amount of contraction, but it's dependent on calcium. What does calcium have to do with contraction?
When it goes into the cell.
Yep.
Causes the depolarization.
Depolarization is more linked to sodium. What does calcium do? I mean, yes, calcium technically does depolarize also, but it's more directly linked to contraction. What does calcium do for contraction?
It activate myosin.
You're in the right neighborhood, you're not quite there, and I'm going to take it the rest of the way. Calcium. So she said it activates myosin, which is not really what it does, but it gives myosin the chance to do what it needs to do. Calcium binds to troponin. Troponin moves tropomyosin out of the way so that the myosin binding site's available on actin so that myosin can bind to actin and cause the thin filaments to move. So it gives myosin the ability to do what it's going to do, but the calcium is bound to something on the thin filament that sort of opens the thin filament up for it. The more calcium that's present, then the more the myosin can interact with actin directly. Okay, so contractility can be increased or decreased just by playing with how much calcium is present in the cell. Now, I'm almost positive last time I talked about what's special about calcium in cardiac muscle versus skeletal muscle. What's different about calcium in cardiac muscle? Where does it come from?
Outside the cell.
Yeah, outside the cell. As opposed to where does it come from in a skeletal muscle? Yeah, that thing. Yeah, the sarcoplasmic reticulum, or inside the cell. Now, there very well might be sarcoplasmic reticulum in calcium cells too, but the plateau of the cardiac muscle action potential is because calcium is entering into the cell, keeping it depolarized, extending the amount of time it spends contracting. And all of that calcium which is affecting the membrane potential, is also increasing the amount of contraction possible because just more calcium come into the cell. Anything that increases the amount of calcium that comes into the cell increases contractility. Anything that decreases it decreases calcium entry, decreases contractility. Now, before I define afterload, let me just put that in here. And I'll get back to afterload in a second. But in the book, this figure here actually is going to, where'd it go? Address contractility a little bit, as well as some other things. So this is, and I'm going to come back to this figure to explain all of it, but this is essentially how the autonomic system controls the heart. I'll talk about where these things are coming from in a little bit, but the top, what color would you call that? Pink?
Yep.
Yeah. Okay. Pink line is the vagus nerve, which synapses at a terminal ganglion right by the heart, and then the postsynaptic fibers go to the SA node and the AV node and slow down heart rate for resting heart rate. The purple line represents, and it's not anatomically accurate what it's representing, but represents the postganglionic sympathetic fibers, which also go to the SA node and a branch goes to the AV node, speeding up heart rate. But the sympathetic fibers also continue on and branch out to synapse on the ventricular wall directly. So where we see both sympathetic and parasympathetic input here and here, that's the SA node and the AV node. But where we just have the sympathetic fibers ending on the wall of the heart by themselves, that's just going to the ventricular wall in general. And on those cells, the sympathetic activity increases calcium flow through the membrane, increases contractility. So the sympathetic system can increase that. I'll come back to this picture in a sec to explain a little bit more, but I just want to point out these fibers ending on the wall of the heart by themselves without any pink parasympathetic competing input actually control contractility, control calcium flow into the cardiac muscle cells of the ventricular wall. Okay. So the third thing I wanted to describe is afterload, which is the competing pressure in the aorta. If you're going to eject blood okay, during ventricular ejection, you're pushing the blood out of the ventricle and into the aorta. That doesn't happen until the semilunar valve opens, until the aortic valve opens. And the valve opens when ventricular pressure matches aortic pressure. So afterload is essentially the aortic pressure. The higher the pressure in the aorta, the harder it is to even eject blood out of your heart. The lower it is, the easier it is to eject. So low blood pressure is a positive aspect of afterload. High blood pressure is a negative aspect of it. We can control preload and contractility. We have mechanisms to regulate those. Afterload, we actually can't do anything about. If there's an acute or momentary change in blood pressure, then we can affect that. But long-term changes in blood pressure, somebody with hypertension, they're going to have a negative effect on their cardiac output because of afterload. Just if your blood pressure is 145 over something, that 145 millimeters of mercury is what the ventricular pressure has to match to even open up the valves and start ejecting blood. And so that can decrease the amount of blood that can be ejected. You have low blood pressure, and that'll increase the amount of blood that can be ejected. So those are the three main things in this list that affect stroke volume, and really preload and contractility are the only ones that we can directly affect. Now, duration of contraction in this, we also can affect because that's really a matter of heart rate. Okay, it's over here, how fast the heart's beating will have an effect directly on stroke volume. A slower heart rate means that there's more time for blood to fill the ventricle, and there's more blood to eject with each one. So that kind of, I would have liked to have left that off the list because it just sort of muddies up the water, but it is true. And also it's kind of tied to preload, okay? So I showed you throwing the eraser across the room here. For the heart, if you want to increase the amount of contraction, you can stretch the muscles, the muscular wall of the heart out. And basically that you do that by filling the heart with more blood. Okay. And so back to the athlete whose heart rate is low, that's actually going to directly cause stroke volume to increase because in the whole second of time of heartbeat, there's more time to fill the ventricle versus the 0.8 of a second for your average resting heart rate of 75 beats per minute. So a slower heart rate or duration of contraction will actually lead to greater end diastolic volume, filling up the ventricle more so that you stretch the wall out and it contracts more in that time. And then the contractility thing I pointed out in this picture is really under control of the sympathetic system. So let me get back to this picture, talk about it a little bit more. What it's showing us is the parts of the, actually, we're coming up on the end of class, and trying to say this in a minute and a half is not going to do any of us any good. So let's end there. Next time we'll come back to this. I will not need the entire class next time to finish the heart stuff. We'll be done with it in probably about a half hour. So we'll start blood vessels next time too. So if you should complete the concept coach stuff for the vessels chapter by midnight tomorrow night. So just to go back to answer your question. Otherwise, have a nice night. I'll see half of you tomorrow, and everybody, well, we'll see a few of you tomorrow, and everybody else Thursday for class.